morning, everyone. It's a great honor to have the opportunity to present my PhD topic entitled Current Management of Endometrial Cancer. My name is Madár István. I'm a PhD student and an obstetrician and gynecologist specialist at the Semmelweis University. Our team believes that every endometrial cancer patient's life quality and length can be improved using novel methods. This is the reason why our mission is to improve the management of endometrial cancer patients by applying up-to-date scientific results. In order to fulfill our mission, we have set up two specific goals. In the first project, we are going to investigate the transvaginal ultrasound and magnetic resonance imaging in the preoperative stratification of endometrial cancer. And in our second project, we are going to investigate the systemic therapies for recurrent or advanced endometrial cancer. So let's have a closer look to our first project. So endometrial cancer is the most common gynecological cancer, being one of the leading cancer-related death causes among women worldwide. Myometrial infiltration is a crucial role prior to operation, and with a proper myometrial infiltration assessment, we can reduce the number of unnecessarily extended surgeries. We have two major imaging techniques for this. First of all, the transvaginal ultrasound, and secondly, the magnetic resonance imaging. I have to underline here that in case of women desiring fertility-sparing operation, the endometrial cancer has to be low grade. So our clinical question was whether transvaginal ultrasound have similar performance as magnetic resonance imaging in the preoperative myometrial infiltration assessment. And we hypothesized that indeed ultrasound have similar performance as MRI in the preoperative myometrial infiltration assessment. We have done our research in the three major databases, obtaining more than 7,600 articles. And after duplicate removal and the title abstract selection, 18 articles provided to be eligible for the final data elaboration. So let's have a closer look to our results. When we took into consideration all of our endometrial cancer patients regardless of tumor grade, with the transvaginal ultrasound, we obtained almost 77% sensitivity, pooled sensitivity. With regards to specificity, the pooled specificity surpassed 87%. Moving on to magnetic resonance imaging, we can observe that both pooled sensitivity and specificity surpassed 81%. Only 4 studies provided enough data on low-grade only endometrial cancer patients. And if we took into consideration the transvaginal sonography, we can observe that neither sensitivity nor pooled specificity surpassed 75%. If we take a look on the magnetic resonance imaging, we can see that there is an outstanding specificity with regards to the MRI. So summarizing my results in one slide, we can see that the difference between the two imaging methods was significant only in case of low-grade endometrial cancer and obviously just the specificity. As any other studies, our study has strengths and limitations. The case number, the quality of the studies, and the inclusion only of studies which investigated the two imaging methods on the same cohort of population is definitely an advantage of our study. However, the number of low-grade only patients is small, and obviously the different scanning protocols which we faced in different studies can be a source of bias. In the end, we can conclude that transvaginal sonography and magnetic resonance imaging have similar performance. However, significantly better specificity was observed in case of MRI, in case of low-grade only tumors. What does it mean in our clinical practice? It means that transvaginal ultrasound can be the first choice in deep myometrial infiltration assessment. However, in case of low-grade endometrial cancer patients desiring fertility-sparing operation, magnetic resonance imaging can be justified as well. Further studies, we consider that further studies have to be conducted on low-grade only patients and obviously on the correlation of imaging markers and molecular classification. Our manuscript status is as follows, and we intend to submit it within 2 weeks in one of the highly quoted journals in our field of study. So let's move on to my second project about the systemic therapies for recurrent or advanced endometrial cancer. So I have already highlighted the importance of endometrial cancer, and I also have to mention that 1 out of 5 patients will have recurrent or advanced endometrial disease, endometrial cancer. Unfortunately, there is no standard care for second-line systemic therapies. What do we do in case of recurrent or advanced endometrial cancer? We either obtain for a local radical therapy, or we perform a systemic therapy, which can include hormone therapy, cytotoxic chemotherapy, and targeted therapy. So our clinical question was whether combined therapy protocols offer better survival than single-agent protocols, and we indeed hypothesized that combined therapy protocols offer better survival rate. We have done our systemic search, and in the end, we obtained more than 14,000 articles, but after the duplicate removal and the title abstract selection, 109 articles provided to be eligible. So here we are right now with our second project, and we will go on as soon as our first project is submitted and published. Approaching the end of my presentation, I would like to highlight once again our 2 major projects, and obviously the planned submission dates in September and October. And thank you very much for your kind attention.
How do you know, is there any promising biomarkers or of any other factors which is promising for the early diagnosis or following of the progress in endometrial carcinoma in research, not in clinical practice?
Mm-hmm. So biomarkers obtainable from urine, from blood, are not in the spotlight right now. Actually, the molecular classification is what the science is concentrated on right now. So the molecular classification, its prognostic value, its role in the further treatment, especially the immunotherapy and so on, its prognostic value on the endometrial cancer patients, on chemotherapy. This is what the science is right now focused on.
Hi, thank you for your presentation. I would like to ask about the diagnosis of the endometrial cancer, because this is all about the sensitivity and specificity of the stratification, right? So is the diagnostic accuracy better, I mean the sensitivity, because 75% or more or less 80% of sensitivity for diagnosing a cancer seems to be a bit varying to me. And how do you diagnose, and is there better sensitivity for that?
So I might have not highlighted enough that this is a preoperative stratification. This means that usually we have a histological sample before this imaging method, yes, and afterwards we have the operation and we will obtain the final histological sample. These imaging methods were compared to final definitive histological samples. But if we take into consideration the other methodologies we have for the preoperative stratification, I think these 75% is a pretty good number.
And how do you decide on which patient you will take a sample? Is it also by transvaginal ultrasound?
Not compulsory. Actually, in case we have the suspicion for endometrial cancer, and we have several criteria where we should perform the biopsy, then we will perform the biopsy. This will this will get us a result, and afterwards, during the operation planning, we will perform the ultrasound and the MRI.